Coming. He practices urology in the UK, and he has really been a pioneer in this field, not only in his own specialty, but as you'll hear, helping his general surgery colleagues as well.
Good morning. Thank you for those kind words, Danny. It's a pleasure and a privilege to be here. I used to be a general surgeon in another life, so that kind of kicked it all off in a way. My remit is to kind of go through what we've achieved so far over the past 2 or 3 years, and certainly there's a bit of bias towards urology because I feel that I'm more qualified, if you like, to discuss that. But I've tried to keep it simple and interesting. My disclosure is I have an honorarium which I've received from Covidien. I am not a big surgeon, whereas Lloyd Moynihan was. He used to make very big incisions. I presume all of you over here are unfortunately going to be small surgeons because you're here to learn how to make either very tiny incisions or no incisions at all. These are the terms used to date to describe the procedures that you have heard the previous speakers describe. And I've brought this up primarily to highlight the fact that it's not the term, it's the procedure that is what is at stake and what we're discussing. And the reason we need a common form of terminology is to actually compare apples with apples and not compare apples with oranges. When we are describing a procedure, we need to have a common form of understanding. Even if you look at Medline, and this was an old slide, I stopped looking at these after sort of November last year, because you can see the number of terms and citations that you get when you talk about one of these acronyms. So I think we've gone down on the term less because I think it is colloquially apt, it's scientifically accurate, and certainly all the urological publications that are now coming out are using less as the standard to describe how these procedures are carried out. This slide reflects what we did way back in 2007. I believe we did the first ever laparoscopic nephrectomy using a single port. And we have certainly helped some of our general surgical colleagues develop their techniques. Prashant Rao is another pioneer in the field, and he, I believe, did a number of the first single port lap choles. So what has been achieved so far in general surgery is what you see. I might have missed out a few other procedures that are currently being carried out. Same with gynae and same with urology, especially with urology. What can be carried out with conventional multiport laparoscopy is now being carried out by single port procedures. This was the original feasibility article that we wrote and submitted to HPB. And that was our initial kind of takeoff, if you like, to see whether we could actually take this procedure further. And the fact that all of you are here now is testimony to the fact that I think it is here to stay. I'm going to just run through what happened over the last few years. There have been a few key players in the field, and I'm proud and privileged to be associated with a few of them, Scott Danny and Paul being one of them. I went down to the institution to see how they did their procedures, and I learned from what they were doing. Homero was kind enough to show me around as well. But then there's the other team at the Cleveland Clinic, which also took on the mantle of kind of driving the innovation forward. And a lot of papers that have been quoted, certainly in the text, are from the clinic. We reviewed what was in the literature maybe about a year ago, and we compared the pros and cons of single port surgery with notes. Donor nephrectomies have been done. This is the one paper in the literature that actually shows a significant difference in the postoperative parameters of recovery, including pain and postoperative stay. They were significantly shorter in the patients who had what he described as E-notes nephrectomy, or what we would now describe as less nephrectomy. So where are we going? I think the future is bright. You've seen a number of innovations, and I'm sure that there will be more coming in the next several months. You just have to go down to the stands and see what industry has to offer. The radical prostatectomy is probably the most difficult operation that we do as urologists, technically challenging, and even that has been accomplished by single port surgery. I don't, however, know at this point in time as to whether it is going to become a standard of care. And the devices, well, you've got pretty much one or two for every company. And I think this has been challenging for us as surgeons and has been challenging for the device companies as well, because we want better instrumentation to help us do a better job. And I must say that they have responded with flying colors and are giving us good kit. And I think it's just a matter of time before everybody gets up to speed with the new instrumentation that will be available. And some of those have been described in this paper that was published just this month. Do we have a robotics option? And I think it's only fair to think that robotics will come into this. After all, it does help precision dissection, and maybe we'll see instrumentation being developed specifically for robotic applications. But at this point in time, there doesn't seem to be specific instrumentation available. I'm sure it will develop. What are the benefits? Well, there's only one that we can put your hand on your heart and say, this is it. This is the advantage. You can argue the other pros and cons, but I think cosmesis is the one single advantage that you can quantify. We need more data on ambulation and recovery, and that is being accrued as we speak. What would you like? Would you like something like this? I think this is true keyhole surgery. This was the young lady in question, and I put this up because I was very surprised. This was sent to be one of my residents. It came out in the week, I think last week. And it just goes to show that there is a huge degree of interest in this procedure, even in the lay press. And at the end of the day, I think with less we win. Toyota kind of saw this. I don't know whether you can see, but it's projected. This article was printed, this advertisement was printed on the 12th of March 2008. That was exactly 1 week after we did our first laparoscopic nephrectomy in the UK. I leave you with this. Thank you very much. Bigger is not always better. Thank you.